Well, I hope you enjoyed your lunch. Welcome back for the afternoon session. Our topic is going to shift a little bit from the morning. And this afternoon, we're going to discuss the concept of therapeutic misconception. And this will be introduced by our speaker for this first session, Dr. Paul Applebaum. Dr. Applebaum is the Elizabeth K. Dollard Professor of Psychiatry, Medicine, and Law, and Director, Division of Law, Ethics, and Psychiatry, Department of Psychiatry, College of Physicians and Surgeons at Columbia University. He directs Columbia's Center for Research on Ethical, Legal, and Social Implications of Psychiatric, Neurologic, and Behavioral Genetics. The author of many articles and books on law and ethics in clinical practice and research, Dr. Applebaum is a past president of the American Psychiatric Association and the American Academy of Psychiatry and the Law, and twice served as chair of APA's Council on Psychiatry and Law. He now chairs APA's Committee on Judicial Action. He has been elected to the Institute of Medicine of the National Academy of Sciences. I am pleased to welcome to the podium Dr. Paul Applebaum.
So thank you very much. It's a pleasure to be here. I always love coming to Chicago. It's a wonderful city, and it's been a couple of years since my last trip. So I had the pleasure of walking through Millennium Park yesterday afternoon and just seeing the development there, which I'd not seen before, which is phenomenal. But what I'm really here to talk about is this phenomenon that we described 30 years ago now, called therapeutic misconception. And let me tell you about the case that sort of crystallized our thinking about this concept, and then we'll move into the research and what we understand about it today. We were studying other people's research, which we've done for many years, and after investigators obtained consent from their research subjects, we were interviewing them to see what they had understood or not understood, and there was an experimental intervention, which is not relevant to what I'm going to tell you about today as well. And this particular subject was a 25-year-old woman with 3 years of college who had enrolled in a double-blind, randomized, placebo-controlled clinical trial of 2 medications for borderline personality disorder. At the time of the initial interview, and I was the person who did the interview, she really displayed minimal, maybe almost no psychiatric symptomatology. If you had run into her on the street or at a cocktail party, odds are, based on a superficial interaction, you would not have known that anything at all was the matter. And as I interviewed her, it became clear that her understanding of the research study in which she just enrolled was generally terrific. She recognized that the purpose of the project was to find out which treatment worked best for the class of patients of which she was one. She spontaneously described the 3 groups, including the placebo group, and she indicated that assignment would be random. She understood that dosages would be adjusted according to blood levels and that a double blind would be used. When she was asked directly, however, how her medication would be selected, she paused for a moment and she said, "I have no idea." And then she added, "I hope it isn't by chance." But suggested that each subject would probably receive the medication that he or she needed. So given the conflict between her earlier description, right, even her use of the word randomization, and her current explanation, I pursued it a bit with her, and I asked her what her definition of random was. And the definition was textbook perfect. By lottery, by chance. One patient who comes in gets one thing, and the next patient gets the next thing. And then she began to wonder out loud if that's what would happen in this study. But ultimately, she concluded that it would not. So we have here an enigma, a bright, college-educated, 3 years of college, relatively asymptomatic person who, in many respects, displayed an excellent understanding of the research in which she had just enrolled, and who yet at the same time seemed in some very fundamental way not to get it, not to appreciate what she was about to enter into. And when we describe this case and others 30 years ago now, we call this phenomenon therapeutic misconception, which we defined as something that occurred when a research subject failed to grasp the distinction between the imperatives of clinical research and of ordinary treatment, and inaccurately attributed therapeutic intent to research procedures. So this was a woman who had come into this setting with a therapeutic mindset, which, based on her, understandably, on her previous experiences with physicians and other treaters, had taught her that they tried to do what was best for you. They picked the medication, the dosage that they thought would be most helpful to you, and despite the information that she had received, concluded that that was going on here as well. Now, to understand something about the nature of the dilemma created by the therapeutic misconception, we have to touch at least briefly on the ethics of treatment and compare them with the ethics of research. So the ethics of treatment, as I suggested a moment ago, have as their primary goal the provision of what the legal philosopher Charles Fried has referred to as personal care, by which he meant that the physician or other treater who you are seeing would try to do his or her best for you and make decisions insofar as they could in your interests. Now, any physician might be wrong in diagnosis, in selection of a treatment approach, but our expectation in that context, in the clinical context, is that they're going to do their best for us. They'll do their best to make the right diagnosis, do their best to pick an effective treatment. And that's the presumption of the medical profession and the formal ethics of the profession as well. Research, however, is a very different circumstance. In research, the primary goal is the production of generalizable knowledge, not necessarily the provision of personal care to each and every research subject. And we have a number of techniques that we use in research that, in fact, if used in ordinary clinical treatment, would be clear deviations from our obligation to provide personal care. And I've listed some of them. Random assignment is something that is common in research and for good reason. But if you walked into your internist's office and he or she, after examining you, said, if you could just wait a second, I want to reach into this drawer here. I have a sealed envelope I'm going to pull out that's going to tell me which of several medications I should use to treat you. You might understandably be upset. I doubt if anybody would blame you for walking out at that point and trying to find a different physician who had some other basis for choosing your treatment. Placebos are commonly used in research settings. Even there, they tend to be, in some circumstances, controversial. But they are these days rarely used in clinical settings, and when used there, always controversial. And there's a whole literature on whether placebos have any legitimate use in general treatment. Double-blind, adherence to the protocol to determine dosages, both starting dosages and adjustment ranges. So after 2 weeks, we can take you up by 5 milligrams or take you down by 5 milligrams, but not 10 milligrams in either direction, because that's not what the protocol says. and limitations on adjunctive treatments. So let me go to my field of psychiatry. For an example, if you're in a study of medication for depression, one of the outcome measures may well be your sleep patterns. And therefore, adjunctive sleep medication is something that would be precluded by your enrollment in the study, but absolutely not precluded in ordinary treatment, where when we see new patients who are depressed and we're starting them on antidepressants and they're having a great deal of trouble sleeping, we might well give them a short-term prescription for hypnotic medications to help them get some sleep, get some rest, break this cycle while the antidepressant is beginning to take effect. Now, I don't want to suggest that any of these and other techniques that we use in research are necessarily illegitimate. Used properly and for good reason, they're not. But they are very different from what we do in ordinary treatment. So where does this phenomenon come from, this confusion between what we do in ordinary treatment and what we do in research? This is from a later study we did about not quite 15 years ago now, in which similarly we interviewed subjects, taped the interviews after their consent to involvement in research. Let's just read it through together. Our interviewer asked, not me this time, "Do you know how treatment in this study is different from ordinary care? Did they say what your treatment would be if you weren't in the study?" And the subject says, "No, no." "They didn't discuss what the treatment would be?" "No, no. I'll leave that up to them. I want them to give me the best treatment for what I have." "Do you think by being in the study this is the best treatment you could get?" "Okay, if they don't, then I'll drop out." "So hopefully they will give you the best treatment you can get." "Right, right. So you're not sure that they have different groups or anything. As far as you know, if they did have different groups, would the doctors decide which is the best one for you?" "I would assume he would decide which one was the best one for me." Now, this is a patient who is by no means an ignorant person, but someone who has had a lifetime of experience in clinical settings and has just transferred that experience into the brand new research setting in which he has found himself. And his assumption, although logical, this is what people in white coats with stethoscopes around their neck usually do, could not be said to be accurate in this case. So part of where therapeutic misconception comes from, I would suggest to you, is from the world of clinical care and the experience that patients have in that clinical care. But that doesn't mean that that's the only origin of therapeutic misconception, because there are things that researchers do and do routinely that contribute to it as well. For example, researchers use acronyms that are designed to be catchy for their studies. You heard this morning about the CAFE study and the CATIE study. But some studies have somewhat, perhaps more problematic names. How, after all, could you say no to a physician who asked you to sign up for the best study? Much less a study that promised not just treatment, but magic. Or, if you were in need of one, a miracle, and was going to do that with something that was as far from an experimental intervention as possible. They were going to use something that was proved. Little wonder that patients might see the acronym on the consent forms that they were asked to review before they became research subjects and conclude that this was definitely the study into which they wanted to be placed. We also use words in other ways that convey to potential research subjects that this environment into which they're entering is really not all that different from the usual clinical environment. For example, now I've watched many research disclosures, and I've read dozens, scores, who knows how many research consent forms by now over my career. I have never seen one that talks about what we were asking subjects to enroll into as research. We talk about projects. We'd like you to be part of this project that we're doing, or we're doing a study, or a clinical trial. Clinical trial is an interesting phrase. It means something very specific to us. The average patient, I think, is left clueless by the term. About all they can ascertain is that there's something clinical about it. That's good, because they know how they get treated in clinical settings. Moreover, the interventions are almost never described as experimental. We would never say, we want to give you an experimental medication. That sounds dangerous, after all. We have a new drug. New is good. New is better. A study medication. That sounds good. We're going to study this and make sure it's the right thing. Or sometimes just treatment or therapy. Interestingly, there was a study published in the New England Journal, it must be close to a decade ago now, by Zeke Emanuel and his colleagues at NIH, in which they were looking at consent forms for phase 1 trials in oncology, in which we know the likelihood of any positive response is under 5%. People argue about exactly 5%, 3%, a little more. And positive response doesn't mean cure in general. It means maybe you got an extra 3 months to live. So these are sad situations. And they went through the consent forms, over 200 as I recall, to ascertain the extent to which they were truly leveling with potential subjects about the likelihood of benefit. And the results that they reported and what got it into the New England Journal of Medicine was that the forms were really quite clear that there was a relatively low likelihood of benefit from enrollment in the study. But what they didn't highlight in their article, but you could find in the data if you looked, was that almost all of these studies, a huge proportion of the studies, referred to the intervention as treatment. Not experimental drug or experimental combination, which is what it often was, but simply treatment. An overlooked, but I think important influence on what patients take away, what research subjects take away from these interactions. Let me give you an example of what our use of words, often our use of jargon, can do with a research subject. This is an interview with a woman who's in a study of advanced non-small cell lung cancer with 2 treatment arms. Interviewer: what does the project involve? The research study. What is your participation involved? Well, they choose an arm, one arm, for an operation, the other one for the IV. If they choose the arm for the operation, for the IV, there's no operation involved. Now, our interviewer is completely lost at this point, and she says, if they choose the arm for the IV, there's no operation, says the subject. Oh, says the interviewer, which is probably what I would have said at that point too. If they choose the other arm, then there's an operation. And the subject's looking and pointing at both her arms. Okay, says the interviewer. I don't know what the idea of that is, says the subject. And of course, you don't know, and I don't know what the idea of that is either, but I do know how this happened. This was a subject who was told that she was in a study with 2 treatment arms, right? And she knows what treatment is, and she knows what arms are. And so she concluded quite reasonably that she was going to get treatment in one or both of her arms, and really lost the point of what was going on here altogether. Simple jargon, we use it all the time in research settings, but potentially innately confusing for research subjects. So how common is this confusion between therapeutic and research orientations? This was the very first study we did. These were data we published back in 1987, 25 years ago. Now, we were looking at 4 psychiatric research projects in 2 different research centers and interviewing the subjects afterwards. And we found 88 subjects altogether in 4 studies, that 69%, almost 70%, didn't know that they would be assigned to their condition randomly. 40%, in fact, said explicitly that they expected to be assigned on the basis of their therapeutic needs. The doctor will do what's best for me. 44% failed to recognize the possibility that they might get inactive treatment, what we might call placebo if it involved a medication, though not all of these studies were medication studies. Almost 40% didn't know that the physician would be blind to the medication that they received. Only 9% were able to identify how the protocol would limit any of their treatment options, adjunctive, collateral treatments. And fully half believed that their dosages would be adjusted according to their clinical needs when that was not the case. In some studies that may be the case, but it wasn't the case here. So we published these data, and we went around and gave talks about it. The response that we got was I thought, pretty interesting. I'd give a talk about these data as I'm doing here this afternoon, and people in the audience would say, well, of course. What do you expect? These are psychiatric patients. These are crazy people. Of course they don't understand what's going on. But our subjects understand exactly what's going on. And yet, even then, data were starting to appear that cast doubt on that assertion. So in a study by Penman and colleagues, 43% of 144 cancer patients in phase 2 and 3 trials said they had no doubts at all that they would benefit from being in the trial. And in an amazing study, Schaefer and colleagues at NIH, 100% of 127 cancer patients in phase 1 trials said that studies had both treatment and research aims. Phase 1 are dose-finding trials, right? We want to know how much of this medication can a person tolerate before they get sick. And in oncology, we're talking about potentially very sick. Phase 1 trials do not have therapeutic aims. They may, on occasion, have therapeutic benefit, but they don't have therapeutic aims. When the commission appointed by President Clinton to look back in time at the human radiation experiments that had been funded by the federal government issued its report in 1995, they reported on a survey of more than 500 former research subjects. And among a whole slew of really very interesting findings, they showed that most of them didn't believe that physicians would offer them a study that wasn't in their best interests or that posed significant risks, when of course physicians do both of those things all the time. So to follow up and set this canard that, oh, it's just psychiatric patients who have this problem to rest once and for all, about 15 years ago, we did a study. Chuck Lids, who was one of my co-authors on the original papers describing therapeutic misconception, was the PI on this grant, in which we looked at almost 250 people at 2 different academic medical centers, 44 different clinical research studies, clinical trials, average age, mean age, 53 years, 70% female, overwhelmingly white, well-educated, halfway through college on the mean. These were the studies that they were part of, and you can see that they range from life-threatening conditions such as cancer or potentially life-threatening hepatitis C, heart disease, to medical nuisances, if you will, such as plantar warts, and including a small number of studies of psychiatric conditions, but overwhelmingly we're talking about general medical conditions here. We defined, for the purposes of the study, therapeutic misconception as based on two dependent variables: an incorrect belief that the participants' individualized needs would determine assignment to treatment conditions or lead to modification of the treatment regimen, which we call the individualization dimension, and an unreasonable belief about the nature or likelihood of medical benefit from being in the study based on a misunderstanding of the research design, which we referred to as the benefit dimension. And we collected all kinds of independent variable data as well. So with regard to the frequency of therapeutic misconception, these were based on transcribed interviews that were double scored to establish reliability. Just over 30% of the subjects had evidence of therapeutic misconception with regard to how their treatment would be selected or adjusted, and just over half had similar misconceptions with regard to the likelihood of benefit, based on erroneous beliefs about the methods or nature of the study. For example, that an experimental medication was being offered to them because it would certainly help them. That's why their doctor wanted them to be involved. There was considerable overlap, so roughly 62% of subjects manifested one form or another, or both, of therapeutic misconception. The variables associated with therapeutic misconception: age. The older you are, the more prone you are to experience what we call TM, if you'll forgive me for the abbreviation. And the less well-educated you are, the more likely to experience TM. We also looked at functioning. This is the SF-36 general functioning scale, and as you can see, almost everything correlates significantly except bodily pain. So the more distressed you are in a variety of ways, the more impaired you are, the more susceptible to therapeutic misconception. When we did a multivariable analysis looking at participant level variables, we found that people who had more pessimistic views of their current medical condition, that is, who thought they were sicker, but were more optimistic about how they would be in 6 months and a year, were more likely to manifest therapeutic misconception. So if you're ill now, but you're really hopeful that things will get better, you come into this with a mindset that appears to predispose you to thinking, this is really going to help me, they're going to do their best for me when you enter into a research context. And this is the multiple regression of study level variables. And this is actually sort of interesting, but by no means straightforward. So if the consent form said that death was a possibility as a result of being in the study, you might think that would reduce the rate of therapeutic misconception, but it was associated with a higher rate of therapeutic misconception. Moreover, if subjects were told that FDA-approved medications existed for their condition outside of the study, that also increased the rate of therapeutic misconception. So we looked at this and really were perplexed. You can see there's an enormously high R-squared here in terms of the percent of the variance accounted for, which you rarely see in studies of this sort. And I have a way to suggest how to put this together. I'm not positive that this is the conclusion you should draw, but let me try it out on you. If death may occur in a research study, that's usually because you're already very seriously ill. For example, you have cancer, and we're using heavy-duty medications that may well have heavy-duty side effects and consequences for you. So this may be a proxy for sicker patients. FDA-approved medications outside of the study. Now, you might think if a subject understood this, they would understand that what they're getting into is very different from ordinary clinical treatment, because there are approved treatments that they can have elsewhere. But I would suggest to you that what's going on here is that subjects are concluding that if there are approved medications outside of the study, and the doctor is offering me something else, this must be even better than those approved medications. Otherwise, the doctor would give me the approved medication, which is clearly otherwise the best thing to have. So put those two together, and they significantly heighten the risk of therapeutic misconception. So here are a couple of examples of what this, a couple more examples of what this looks like in practice. Our interviewer. Okay, what's the primary goal of the project? Meaning, is it going to help people in the future, or is it going to help people in the project, or a combination of both? Oh, I expect it to help me. I feel like I'm already cured, but I expect it to make absolutely sure that I am. And to decrease the risk of it coming back. Okay. And absolutely to help people in the future so they can measure my success. Help people, help monitor. They need people to study. So this is a woman with disseminated breast cancer who was in a study. This was back when we were doing bone marrow transplant for breast cancer, which turned out not to be a successful approach. She had agreed to participate in a study of 2 different adjunctive medications for people who were having bone marrow transplant. The likelihood of success, first of all, she wasn't cured. Second of all, the likelihood of success was very low. And third of all, the study into which she was entering really had nothing to do with whether or not she got bone marrow transplantation in the first place. So this is another one of these sad examples of a research subject who really was in a pretty desperate situation and really appeared to let that influence her perspective on the study in which she was enrolling. Different patient now. Interviewer. I like this guy. Interviewer. What made you interested in the project? Nothing. This is an older guy. Interviewer. Nothing? No interest in it. She says it could help keep the platelets off my stent. Okay. Double dose, I guess. Is that what made you decide to be in the project? That's a possibility? Yeah. So this older working class guy is entered into a study. He's had a cardiac angioplasty with the insertion of a stent for narrowing of his coronary arteries. And he was getting a medication that was supposed to reduce clotting and closing off of the stent, an antiplatelet medication. The study was comparing the usual dose with double dose. That's what the study involved. Interviewer. Is the treatment the same for everyone in the study? According to what the research nurse said, that everybody gets the same thing. Whoops. And one gets the double dose? Our interviewer is a little hung up on the protocol here. Subjects beyond that. Everyone that had the angioplasty gets the same thing. The same treatment, I mean. There can't be much of a variation as far as I know. Okay. She says, the way she stated it, she says, we're doing this to people who are having angioplasty. She probably did say that. Right. So, same treatment for everybody. So, everybody gets the double dose? Everybody gets exactly the same. Now, this is a fairly reasonable conclusion if your assumption is that there is a right way to treat whatever your condition is. And if that's the case, then that's got to be what you get. And that's got to be what everybody else gets as well. So single dose, double dose, whatever the right one is, that's what you're going to receive. A little later in the interview. True or false? I chose to join the research project. Well, I had this thing in my heart, and if I didn't, I was afraid, you know? So this is what is driving the decisions of many research subjects. Fear for their condition, hope, in fact, hope at the level of certainty that if they enter into the research study that it will benefit them. Since we're focused on translational research today, I just wanted to give you an excerpt of some data from a more recent study in which I was involved. Laura Dunn at UCSF was the PI on this study. We looked at 32 subjects with treatment-resistant depression who were recruited for studies, actually 2 separate studies at 2 different sites, of deep brain stimulation, right? Insertion of electrodes into the subgenual portion of the anterior cingulate, stimulation over a prolonged period of time. Some evidence at the time this study started, a little more now, that this would be beneficial to people who had failed 5 other treatments for depression, but still pretty experimental, right? And electrodes in the brain. Among the questionnaires they received was an 8-item question on therapeutic misconception. Let me just review some of the data with you. 11 of the 31 answered all the items correctly. 12 missed 1 item, 7 missed 2 items, 1 missed 3 items. Altogether, 65% of participants incorrectly answered at least one of the TM items related to the study's purpose, likelihood of personal benefit, or individualization of treatment. And you see these numbers. You remember that the number in our earlier large study was 62%. You see a range of 60 to 75%, roughly, popping up in study after study. This is from the same study, that the items on the scale most commonly answered incorrectly. This study is mostly intended to help me. Whoops, 22% said yes. The research physician can't add any other medication for depression during the first 7 months of the study, even if he or she thinks it would help me. The right answer is yes. 22% said no. In other words, 22% believed that their treatment could be individualized if they weren't doing well, when in fact that was not the case. And then finally, my own treatment for depression will certainly be improved as a result of this study. Almost 20% endorsed that certainty of benefit, despite the fact that they had a highly refractory disorder that had failed at least 5 treatments, and at one of the sites, one of those treatments had to be electroconvulsive therapy, which is the most effective treatment for depression. So what we have done most recently has been to develop a scale to measure therapeutic misconception. And our motivations for doing so came from watching this literature over 30 years and realizing that most studies that are in the literature, and by now there are dozens from many parts of the world, have used open-ended interviews rather than formal structured assessments with varying definitions of what constituted therapeutic misconception, and that the lack of a validated measure has really reduced, stymied, if you will, research in this area. So we recruited, again, Chuck Lids, my colleague at UMass, was the PI. We recruited 220 subjects from 4 academic medical centers, Columbia, UMass, University of Michigan, and UCSF, who completed a 28-item Likert-type questionnaire with items for each of the 3 theoretical dimensions of therapeutic misconception: individualization, benefit, and purpose, each at 3 different levels of application: research in general, this particular project, and your own treatment. And we engaged them in a semi-structured interview, which was then coded for the presence of therapeutic misconception. This was our gold standard comparison for the scale that was being developed. We retained 10 items in a 3-factor model was based on the factor analysis with excellent internal consistency. And these were the items. Let me just read one or two. This study is designed to give everyone the type of treatment and the amount of treatment that best fits his or her individual needs. So the right answer would be false. We actually did this on a 5-point Likert scale. I'll give you one other example. The reason I was asked to be in this study is that it will provide me with the best treatment available. So you get an idea of the things that we were asking. And then we coded the interview for therapeutic misconception. This was our gold standard. Here we had about half of the subjects have evidence of TM on at least one of these three dimensions. This is the discriminant validity of the instrument. If the interview scored them as having therapeutic misconception, they got a 33 on the scale. If a 50-point scale. If they were scored as not having TM, they were at 22. This is a highly significant difference. And all of the individual scale differences, purpose, benefit, and individualization, were highly significant as well. With regard to predictive accuracy, I'm going to show you the ROC curve. We've done more elaborate analyses as well. This paper will be published shortly in clinical trials. I just saw the proof, so probably the next couple of months. If you just look at the solid line for any therapeutic misconception, you can see that the area under the curve is 0.7, not 0.9, which would be great, but not 0.55 either, which would be pretty miserable. And that's about where a lot of behavioral predictive measures fall, roughly 0.70, give or take a small number of points. So we're hopeful now with this scale in hand that it'll be possible, really for the first time, to measure therapeutic misconception validly and reliably. The scale will be published with the paper, so anybody can use it. And we're hopeful that this will enable more systematic studies of prevalence, characteristics, correlates. But it's our very strong belief that the most important work to be done at this point is on how we reduce the incidence of therapeutic misconception. And that's almost not been addressed at all. How do we help research subjects really understand, really appreciate what it is that they're getting into? How do we help them without either taking 5 hours to do it or scaring everybody away from the treatment setting to understand that this really is different from ordinary treatment, from the research setting, really is different from ordinary treatment, and has unique characteristics that they ought to know about before they decide whether they want to participate. And I think that's really where the research of the future needs to go. So let me conclude with this. There are, I think, normative reasons to want to disabuse people of therapeutic misconception. That is, I believe strongly and have for a long time that if you don't get how research is different than clinical treatment, you're not really in a position to give a meaningful informed consent to enter into a research study. On the other hand, because I often run into pushback from a lot of clinical investigators on this subject, I've taken to pointing out that there are also selfish reasons for the research community to want to disabuse subjects prospectively of this notion. And this is an example of this. This is from an article from the New York Times 18 years ago now. Time passes quickly. An interview with a former research subject who later filed a lawsuit against the researchers at his institution. It's not a secret, given the headline, where the institution was. This was a research subject who had schizophrenia, but who was a high-functioning guy. He was in law school. And he entered into a research study that involved a year of stabilization on a medication, Prolixin, an antipsychotic medication, first-generation drug, that was then followed by discontinuation of the medication, complete discontinuation of the medication. And why would anybody want to do that? We know that 80% of people with schizophrenia after discontinuation of medication will relapse over the next 2 years, which is a good argument for keeping people with schizophrenia on the medications. But the medications have a lot of side effects. So if we could identify who those 20% are who really don't appear to need it, aren't going to relapse in the near future, without it, we could save a lot of morbidity for these people. That was the rationale for doing the study. And on its face, it's not an irrational basis for motivating a research study. The problem comes when we ask how well the subjects who were entering into the study understood that this was a study designed to lead to the relapse of 8 out of 10 of the research subjects. This young man was in law school at the time, signed up for the study, had the medication withdrawn, was good while he was stabilized for that year, had the medication withdrawn within a few months, relapsed, dropped out of law school, assaulted his parents, and it took months to persuade him to go back on the medication. And this was his description, after the fact to be sure, but nonetheless his description of his motivations for enrolling. He said basically, I had been delighted to get into the research program because I thought I was going to get the premier treatment while they did a little research on the side. And as long as that remains the case, as long as that remains the view of a substantial number of research subjects, the field as a whole risks losing the broad support that has characterized medical research since the end of World War II and the growth of the National Institutes of Health, not to mention personal consequences, such as having to face a lawsuit or adverse publicity from disgruntled research subjects who, in the end, figure out what was really going on. So whether you want to do it out of self-interest or you want to do it because you think it's the right thing to do, helping people truly to understand what they're entering into seems to be indicated in both respects. So let me stop there and let me take your questions and your comments about this. So there was a hand right on the aisle here.
I want to thank you for your presentation, which was very interesting. And I'm wondering sort of about the ethics of engaging in research on the therapeutic misconception. What do you and your interviewers do when you encounter someone who has agreed to participate in a study and the interview shows that they clearly think they're getting treatment instead of participating in an experiment?
Yeah, so that's a very good question, obviously a very important question, and one that we've worked with IRBs about for many years since we first started doing this kind of work. What we do is we suggest to the research subjects that maybe they want to talk to the research staff, the other research staff, not our research staff. Remember, if they're already confused, we now have 2 research projects that they're involved with, ours as well as their primary study, about exactly what's involved in the research. We've decided, the IRBs have agreed, that we're not in a good position to do that for them. And at the same time, to go directly to the researchers and say, you know, this subject really doesn't get it, puts us in the position of you know, tattling, as it were, on what the subjects told us, which is an awkward situation to be in as well. And so we encourage the subjects to go back and talk to the primary research staff.
I have always been very interested in the placebo effect of the research study. In the clinical trial, we see 20 to 30% therapeutic efficacy of placebo effect. And I wonder if you think that therapeutic misconception may at least partly be responsible for such effectiveness of placebo.
So it could be. Obviously, I can't say for sure, and I've heard that suggestion raised before, and I think it would be, in the right kind of study, interesting to explore. I would note that there are both old data and very new data, and you may know these better than I do if you're interested in placebos, to suggest that even when people are told that they're getting placebos, the placebo effect appears anyway, which is a very interesting phenomenon. And it raises all kinds of questions like, well, they're told, but do they really understand? Do they know what a placebo is? Do they get it? But if they do, so one interpretation is that it's not just not knowing that you're getting an inactive, pharmacologically inactive intervention, but the process of waking up in the morning, taking your medication, feeling as though you're taking something, you're putting it into your body, you're doing what your doctor told you to do, that whole complex of behaviors actually enhances the placebo response. Very interesting area.
The second question is, have you considered doing the study on this therapeutic misconception on those subjects who refuse to participate? Yeah,
so we've considered this for 25 years probably. It turns out to be remarkably difficult to do. Not for the reason you would think, because you might think, well, if they said no to that study, they're going to say no to your study, so it's going to be hard to recruit them. That may be true, but actually we don't know that that's true. The reason we don't know that that's true is because that's not how research recruitment works. The way research recruitment works, almost nobody refuses to be in a research study. Clinician or investigator approaches a patient and says, we're doing a study here. Would you like to hear more about it? And patient says, I don't think I'm interested. I don't have the time. I don't want to be a guinea pig, whatever the reason is. And they never hear about the study. That's how most people get excluded. But often there are several additional steps along the way, right? The screening step and maybe some initial informational disclosure. By the time you get to the full informed consent, people are there because they want to participate. They've decided, almost no matter what they hear, they want to participate in the study. Almost nobody says no at that point. And those are the people who you might want to capture because they've been fully informed and they've decided not to participate, but they almost don't exist. I won't say never, that's not true. But they're actually rare, much rarer than you would think.
Okay, we have time for one more question.
Thanks. Just following up on her question before, since the placebo effect is so large, have you done any studies with the therapeutic misconception and what the outcome is of some of these studies? In other words, the people that do have therapeutic misconceptions, do they have a better outcome in drug studies? Or have you looked at any of that?
We have not looked at that. You'd need a very large sample, probably much large, because this is the largest study, which has had over 200 subjects, was split among 44 different research studies. So it's not impossible to think of doing, but it's actually not so easy to do. You'd probably have to hook yourself onto a multi-site study so that you had access to their full sample. One of the realities these days, many of you probably know this, is that in any given site, given the preponderance of multi-site studies, you're only seeing 6 or 8 people recruited for a particular study. That's the quota that each site gets, and this is whether it's pharmaceutically funded or whether it's NIH funded. Many of them are, so many of them are multi-site studies today. We did, by the way, and let me, because this will be of interest given this morning's discussion, for the most recent data, we did look at, because somebody in a talk asked the question, I thought, gee, that'd be interesting to know, whether there were different rates of therapeutic misconception for pharmacologically funded studies, the drug companies, pharmaceutically funded studies, or government-funded studies, NIH-funded studies. And the answer was no, which, given the overall high prevalence, you might have expected, but in fact, that's what turned out to be the case. All right.
Okay, thank you.